Okay, guys, this is the last part of our anaphylaxis tutorial. So, we said that with anaphylaxis, it's multisystemic, and we said that we have our lungs involved. Our lungs are involved, right? And we said that the issue here is a smooth muscle contraction because of the histamine. So the smooth muscle contraction results in bronchoconstriction, and the patient is going to come in with shortness of breath, wheezes. So basically they've got airway obstruction, wheezes, drop in sets, tachypneic, things like that. So, and we said that our approach would be the ABC approach. So if the sets, so basically what you want to do here is, so this is our heart, hypotension, tachycardia, so basically that's that, and this is due to the massive vasodilation that happens. Then we did speak about the skin, the cutaneous infection, the cutaneous manifestations. The patient is not gonna die from that, so I'm not gonna talk about that. These are the most important ones. So what is important here is that according to your ABC that we spoke about, so you're gonna use your ABC approach as you see this patient. So what is important here is that maintain the airway. If the airway and the breathing is affected, do something about that. But if the airway is patent but they're just distressed and all of that, dropping in sets less than 94, you can start them on O2 mask, and this can get to a point whereby they need intubation. So which means trusting that when we go to anesthesia, we'll master intubation. So it can get to a point where they actually need intubation. But the things that, because I mean, if someone's gonna need intubation, you quickly need to intubate them before, and not try and fiddle and do other things that are not gonna help them. If you can just see that they need to just go on and intubate the patient. But there are things that you can do, and someone is just distressed, they're just wheezing, you can try the give beta 2 agonists, because remember they've got smooth muscle contraction, so they've got bronchoconstriction. So your beta 2 agonist would be your salbutamol. Your nerves, basically nebulize them and try to open those areas. If this does not help, then you might have to go and intubate. And if they're just worsening, now there's just no air, that is just like there is no air that is getting to the lungs, they've got a silent chest, there's just no air movement, then that person will not benefit, because beta agonists, they need the bronchioles must still be at least open, they must still be patent to some degree. But if they are completely closed, then there's no point of giving beta 2 agonists in that patient. They need intubation. We pray and hope that we don't get there. But yeah, so that's what you would do for that. And then for the circulation, the C, to take them out of shock, you need to give them IV fluids, and it's normal saline. That's the normal saline 0.9%. That's the fluid of choice, but if you have Ringer's lactate, you can still use it. But the fluid of choice is normal saline. Because remember, they're hypotensive, you want to boost that intravascular fluid there. So, and then now the mainstay treatment, which should take priority before these ones, is adrenaline or epinephrine. Remember the effects of epinephrine. Remember, we've got endogenous adrenaline. When you are flight or fighting, you bronchodilate your vaso. So the most important thing is that this patient has bronchoconstricted. So once you give them epinephrine, they will bronchodilate. So epinephrine becomes very important. Epinephrine has got also causes vasoconstriction, and you have vasodilation. That's why you've got hypertension. So giving epinephrine will sort out this problem of the airway and also this problem of your cardiovascular. So they will cause vasoconstriction. And we know that once the patient gets into vasoconstriction, according to that formula, that BP is equal to cardiac output multiplied by peripheral resistance. Once you vasoconstrict, you are increasing peripheral resistance. And once you increase peripheral resistance, mathematically, according to this formula, if you increase this, this will increase. Then they get out of hypotension. And then they start perfusing their organs again. So that's why. So it should take priority, and you don't need to look for it. IM is fine, and it's given on the thigh. And so the ratio is that 1 is to 1,000, and then you give 0.5 mils of that on the thigh anterolaterally. That's the big one there. That's the big one. Because what is gonna kill them is that bronchoconstriction and that massive hypotension. So this one reverses that. The other drugs that you give, obviously you've got a problem with histamine. The reason why you are here is because of that flood of histamine that each and every mast cell has been releasing. So you need an antihistamine. The antihistamine of choice is promethazine. 25 milligrams IV. So it's promethazine, but there are protocols that, because we don't always have promethazine, there are protocols that they talk about Fennecan. Actually, Fennecan. I'll double check this, but I think Fennecan is just a trade name of promethazine. But I'll double check that. Because I don't think there is an IV form of allergics. I don't think there is. So it's that promethazine that you give as an antihistamine. Because once you give an antihistamine, you are sort of like stopping the effects of the antihistamine and also trying to minimize the ongoing release of histamine, because we are in this problem because of histamine. The other thing that you give is a steroid, and the steroid of choice is hydrocortisone, 200 milligrams. What else? So we did mention the IV fluids, normal saline, steroid, antihistamine, epinephrine. So these are your drugs. And the adrenaline can give it. Obviously, this patient has got monitors all over. So if there's no improvement, then you can give it in repeated doses, and then later on you need to, if you have to give more and more, then it could be an indication that they need an infusion. There's a complicated presentation that is called a biphasic, which means that a patient can get the anaphylaxis the first time, and then after a few hours again they get a second wave. So which means after taking a patient out of anaphylaxis, it does not mean that all is well. So basically, to make sure that the patient doesn't die because of the biphasic, like the second phase, I think this patient should be admitted. Even if you take them out of the anaphylaxis, but the fact that there's something called protracted, and they say protracted can take about 2 hours. That's protracted presentation or a biphasic presentation. So that's that, guys. That's that. Remember, antigens that are disease causing are called pathogens, and antigens that trigger that causes allergy, they're called allergens. And the body recognizes the allergen as disease causing. The body recognizes the antigen that are not pathological as disease causing, and then they initiate an inflammatory response, and then you get someone now who's got allergy because of that. So the body thinks that these antigens are disease causing, whereas they are not. Like peanuts are not disease causing. They are antigens, right, but they're not disease causing, so they're not pathogens, so they shouldn't have an inflammatory response against them. That's allergy, guys. You can make sure to leave me a comment, and let's hear what you think. So yeah, guys, thank you.